Thank you very much.
Introduction and the possibility to present here some concepts on the fake antigen and how it is inducing anaphylaxis. To understand drug hypersensitivity, you have to start with the beginning. Is the drug an antigen or is it a drug and acts as a drug? And actually, everything in drug hypersensitivity goes about drug binding to proteins, and we have just to consider, is it binding non-covalent or covalent, and is it binding to an immune receptor protein to another protein? If you have this in mind, you can solve all drug hypersensitivity reactions. But the players in the field is very simple. There are normal drugs, most drugs which do not bind spontaneously by covalent bonds to protein, but they bind constantly by non-covalent bindings to proteins like albumin, transferrin, immunoglobulin. That you know, drugs always bind, small molecules bind to the larger molecules. By the way, yes, some drugs are haptens. Haptens are relatively small molecules, they are reactive. They can bind by covalent means to protein. The new complex is stable and big enough to elicit an immune response. It's an antigen. The new complex is an antigen. And then we have the carrier protein, it's albumin, transferrin, surface immunoglobulins, ICAM, HLA, and so on. And the covalent bond means it's also called a molecular bond, that a chemical bond which involves the sharing of electron pairs between atoms. It's very stable, and it forms when you have a covalent bond. You have a new antigen. It's very stable. It's not reproducible. Non-covalent interactions rely on electrostatic interactions, ion pairs, hydrogen pairs. Even though they are weak individually, the cumulative energy of molecular interactions is significant. It can be up to 10⁻⁷ molar. And these can form, under certain circumstances, fake antigen. So, drugs bind to protein first by non-covalent bindings. It's labile, fast, within seconds, minutes. Most of the pharmacological interactions are due to non-covalent bindings. It's reversible, and it's ignored by the immune system. That's what you learned in medical school. All drugs, including beta-lactams, haptens, are binding first by non-covalent bonds. Later, when you have enough energy, the haptens can bind by covalent bond. It's stable, slow, takes hours. It's not reversible, and it's forming a new antigen. And actually, spontaneously, only a few drugs belong to this group, like the beta-lactams, and industry avoids to put haptens on the market because they are afraid of the side effects. Here an example, it's albumin to the left, where for example, amoxicillin is binding, and this is binding by non-covalent links to a certain region in the albumin, and this region also contains, for example, lysine groups, which is symbolized by K, where you later on can find also covalent bonds. And the beginning is non-covalent binding, first step, orientation, because this non-covalent binding tells you where the drug will bind, where is the best situation. It will not bind here, but if you have a pocket here, it will bind here, because it's better hidden, better protected, and has better possibilities to interact. It's fast, within minutes, and here you have the step later, the covalent binding, and the amoxicillin beta-lactam ring opens, and then you have an interaction with the lysine group here in the albumin. And they slow hours, but actually it looks the same. looks very identical from the outside, because it's actually the same binding site and it's the same orientation. So the covalent binding is slow. Here it is shown for when you have a pH of 7.4. It takes more than 4 hours before you can detect any conjugation. When you would have an artificial pH of 10.2, then you have already after 1 hour some conjugation. But in humans, you have 7.4, so it takes 4 hours or longer in order that you can find covalent bonds. And now you have to remember, only the covalent bonds are presumed to make an antigen. The non-covalent is just label binding. Now let's what we see in clinic, anaphylaxis to a beta-lactam, cefuroxime. Within minutes, the patient develops anaphylaxis, cardiac arrest, IV cefuroxime. It's done in perioperative situation. He had a knee operation. The skin test is also positive within minutes, and the blood is also positive within minutes. Now, what you learned in school is only covalent binding makes an antigen. How is it possible within minutes that you have a reaction? How is skin test but occur on so rapidly if formation of covalent bond lasts hours? The question is very simple, or the answer is very simple. You have to be courageous enough to say, no, it must work without covalent bonds. Even more striking example is Bactrim, for example. IgE-mediated reactions to an inert drug, sulfamethoxazole, which is one component of Bactrim, caused in this patient urticaria and bronchospasm within minutes. And she also made to the skin test to Bactrim a positive reaction, a wheel and flare reaction, and a positive but also to Bactrim. Now, this metabolism, the sulfamethoxazole needs metabolism to become reactive. It needs to go into the liver where the cytochrome C209 is working and transferred it to sulfamethoxazole hydroxylamine. And then later on, it is oxidized in the periphery. And then you have sulfamethoxazole NO, which is a reactive compound. This takes hours, 10 hours, and now you have an immediate skin test to sulfamethoxazole. How can you explain it? I asked many colleagues in the last 20 years when they showed me some data and said, how can you explain it? I don't know. So basically, what I would like to tell you is non-covalent binding, which is actually looking very much the same as covalent binding, is the antigen. It's the first antigen. And this is a fake antigen. Yeah? It looks identical for the antibody binding site. This is the antibody binding site. It recognizes amoxicillin here in the groove of the albumin, like here when it is covalently bound. It's the same. And therefore, you make an anaphylaxis. Its fake antigen means it's rapidly, immediately formed drug-protein complexes. This drug-protein complex is based on non-covalent bindings. They are stable enough to interact with IgE, preformed IgE. You have the IgE already. And cross-link IgE bound to Fc IgE receptor. So it's not a very labile binding. It's quite a fine non-covalent binding. Only a few drugs are able to do that, and few proteins, but you have enough. Fake antigens are not able to induce IgE, because for that you need a real antigen, a true antigen. And whatever you see in your clinic, don't forget it, it's due to fake. Immediate allergic reactions to drugs are based on these fake antigens. clinic and tests. That have to be digested. Everything what you learned in medical school is wrong. Just digest it. What is happening? It's these fake antigens immediately formed high amounts and counter IgE-armed mast cells, which are fine-tuned, tolerant for low antigen concentrations. The anaphylaxis to IV drugs, which can occur within 5 minutes after injection, first signs start even earlier. A positive skin prick test, positive ID test to drugs like SMX, and the positive in vitro PAT is always due to the fake formation. And I believe this concept has an enormous impact on our understanding of risk assessment, the clinical interpretation, the cross-reactivity, the prevention, the diagnosis. The diagnosis, it's quite different when you actually have to play with fake antigen. So for the first part, we have IgE and you have a covalent bound. You have a true antigen which is entered by entering dendritic cells presented as a haptenized peptide. And that needs covalent binding. And therefore you stimulate Th2 cells, which secrete T cells and Th2 cells, which help B cells to mature into plasma cells. And the plasma cells secrete IgE and you sensitized mast cells. This sensitization is going along with desensitization because you don't react, and I show you that. But when you make an intermission after 7 days of treatment, 1 year later, you get again amoxicillin. You take a high dose, normal dose, 2.4 grams a day, and suddenly you react because you have a high dose of fake antigen which encounter your tolerized mast cells, but the tolerization is only to the low dose. And fake antigen is not only a fake, it's appearing in very high concentrations suddenly. So you overcome mast cell unresponsiveness. So I summarized this in a paper just 2 years ago, Anaphylaxis to Drugs, Overcoming Mast Cell Unresponsiveness by Fake Antigens. And we discussed now the fake antigen. The second component of this theory is the mast cell unresponsiveness. It means IgE is a useful and useless antibody as long as you don't have the mast cells. But with mast cells or basophils together, they become very potent. So actually, the immune response is regulated not only for IgE, it's also regulated for the mast cells reactive to it. And these mast cells show a certain unresponsiveness. It's a normal and natural process supplementing IgE synthesis to an allergen. In other words, when IgE sensitization occurs, simultaneously, the mast cells, the basophils, are becoming unresponsive to the allergen. However, only to the exposed concentration. Here, this IgE sensitization occurs in the presence of drug. So you have a patient who gets your 10-day therapy with amoxicillin, let's say, and after 2 days it starts to become, it becomes to synthesize IgE, and the IgE is secreted slowly and it's sensitizing mast cells. Initially, only a few mast cells are sensitized and only a few Fc receptors are occupied. After 7 days, medium size of the medium amount of mast cells are already sensitized, but you still don't react. And after 10 days, you have IgE in a high amount, specific amount. You have the drug, and you have mast cell IgE, but you don't have any reaction. You don't detect reactivity. This is because you get desensitized. And the desensitization is actually known to us. Here, again, Mast sensitization and desensitization, what you do in clinical practice. Sensitization means low IgE at the beginning and high antigen, 2.4 gram amoxicillin already, but no IgE or very few. After a while, medium amount of IgE and high antigen, and then at the end, high IgE and high antigen. The mast cell unresponsiveness by antigen IgE complexes and Fc-IgE cross-linking is induced by gradual increase of IgE in sensitization. And in desensitization, you have the opposite. You have a gradual increase of antigen. That means you have already high IgE, but not very much antigen. Then you give a bit more antigen, and you give even more antigen. And then you are tolerized to your compound. That is what you do all the time. This concept of desensitization is a natural concept, and actually your beekeepers, they know that. They often carry IgE to bee venom, and they react in spring to the first bee sting, after days and some more things, no more. Mast cells are fine-tuned again. Rush immunotherapy, you can achieve a tolerance within 3.5 hours by rapidly increasing the amount of bee venom and drug desensitization. Importantly, this mast cell unresponsiveness due to desensitization in already sensitized lasts just 4 to 6 weeks in absence of antigen. You need always to keep the allergen given. Then you can keep it. On the other hand, when you are desensitized already during the desensitization of mast cells, reactivity to the drug, then it lasts forever. It's for life. There's a big difference. So mast cell unresponsiveness is a normal and natural process supplementing IgE synthesis to an allergen. It's normal. The purpose is mast cell unresponsiveness prevents systemic mast cell degranulation to those systemically available allergen concentrations which induce IgE. Don't forget, IgE is depending on mast cells, and it's a locally effective immunoglobulin. It's not a systemic IgE, like IgG or some other ones. Its functions depend on local mast cells. Mast cell reactivity is preserved to higher local allergen concentrations, which you achieve often. It is highly specific. The reactivity by mast cells to other allergens is not affected. The specificity is given by the specificity of the IgE bound to the mast cells. It is very sensitive. Allergens and the interaction with IgE, Fc-IgE receptors are regarding the amount, sensing low and high allergen concentrations, and the speed, how fast you have this exposure to the immune complexes on the surface. Of course, there's a lot to do with regard to the detailed mechanism and further purpose. Anaphylaxis in this concept is due to a sudden increased allergen concentration, overcoming mast cell responsiveness. And it's developed by drugs because drugs are wonderful tools because you know exactly the amount. And sensitization is due to two antigen, covalent drug protein complex, which are formed slowly and induce mast cell unresponsiveness to only low molar concentrations compared to free drug. Anaphylaxis occurs due to the formation of fake antigen. These are formed rapidly in high concentrations and are able to cross-link IgE, Fc-IgE receptors. This overcomes mast cell unresponsiveness. Now, is it relevant also for proteins? Anaphylaxis to protein antigens, the same. The sensitization occurs via small amounts of allergen, namely by percutaneous, remember the story of peanut sensitization, which occurs via skin, or respiratory allergen uptake. This is sufficient to induce a systematic mast cell unresponsiveness to low allergen concentrations. Anaphylaxis occurs when not only local but all mast cells are suddenly exposed to high allergen concentrations, as achieved by parental or oral allergen uptake. The high concentrations overcome mast cell unresponsiveness, and allergic symptoms to protein allergens can occur. So, in summary, they have the term fake antigen. Yeah? Remember it. It can interact with IgE. These fake antigens are based on non-covalent binding between drug and protein, and they are formed and available rapidly in high amounts. The covalent drug-protein complex act like true antigen. They are formed slowly and desensitized mast cells. Mast cell unresponsiveness during IgE sensitization acquires tolerance to the maximal last concentration of recognized allergen. It is specific. Mast cell can still degranulate to higher concentration of the same allergen or many other allergens. However, there are many questions open. Means unresponsiveness, no degranulation, or only part degranulation, etc. And the fine-tuning of mast cells, the allergen concentration during sensitization determines the degree of mast cell unresponsiveness in future in life. With high allergen concentrations at sensitization, the mast cell become unresponsive to high allergen concentrations. You are sensitized, but not allergic. 50% of our people in Switzerland have all the IgE necessary to make hay fever, but they are not allergic. They are fine-tuned, their mast cells are fine-tuned to higher level. They need higher doses. Sometimes they have a breakthrough if really a pollen storm occurs. But most of the time they don't have any symptoms, although they have IgE and mast cells. And if the allergen concentration during sensitization are low, mast cell responsiveness is limited to low concentrations alone. Degranulation may already occur at medium concentrations of allergen, then you are allergic. Thank you very much, and to my colleagues, Lukas Jörg, Daniel Jährli, Oliver Hausmann, Lester, Katja, Florian, Ulrika, Matteo, and so on, for input, discussion, and support. If you need some more information, you can find it on our homepage. Thank you very much.
Thank you, Werner, for this provocative explanation of fake antigen. Yeah, I have a question about that. For example, you mentioned that a covalent binding is still necessary for the sensitization. Yes. Is it really true, or you can also do a sensitization with uncovalent binding?
No, actually, I believe that covalent binding as a real antigen is necessary for sensitization, but I must say that in drug hypersensitivity, the sensitization can often be something else. I mean, most of our patients who are claiming, who show to be IgE allergic to cefuroxime or the radiocontrast media or the chlorhexidine have never been exposed consciously to these drugs. And there may be some cross-reactive compounds which cover a certain part of the molecule and induces already the IgE, the specific IgE. And that is possible. But basically, for generation and immune response, you need antigen. But what I said in the beginning, drug hypersensitivity is not only antigen, it's drug reactivity. And that we have forgotten a little bit.
Yeah. Question from the audience? Yannick?
Thank you very much for the talk. I had a question about your opinion on the CARPA mechanism, on the activation of on the role of the complement in this hypersensitivity reaction.
And the complement of this IgE, of this hypersensitivity reaction.
Yeah, exactly, in the context of certain drugs, allergies.
I mean, IgE is not binding complement. But complement is a different master receptor. They exist, but I think the activation of complement is going via a different pathway. It's not involving this one. I didn't think about complement until now as a component in this hypothesis of anaphylaxis. It means there are some possibilities that you can induce anaphylaxis with IgG against dextran and complement activations. That has been done 40 years ago, before you were born. Yes, already. But that is a very rare exception. It's not very common. I believe for this model here, I can leave out a little bit the complement. Not, the rest of the world, not always. Very important for the clinicians, but we don't understand very much.
One last question then, otherwise we will be late.
Thank you very much for this very nice talk. I have a question about the semantics. You're using the term fake.
Yes.
And you could actually say biosimilar antigen or transitory.
Yes, come on, I want to provoke.
Oh, okay.
Yes. And I was actually, my colleague Katja, she was very surprised because she helped me in formulating it. She said, what? You can publish an article starting with fake antigen?
Well, because the
allergy.
reaction it incurs is not fake.
No, not at all. But the antigen is fake.
Yeah, okay.
It's a fake antigen. I didn't speak about fake.
Well, you could say non-covalent, transitory,
yes,
biosimilar.
Mild, maybe a little bit nice. Yes, come on. Fake is the right word. It's no. I mean, I think also Oliver had the same concern. Fake it was a very abused name. I know, but nevertheless, it is maybe. I think that fake antigens are really horrible. Like the people who use it so much.
Fake or real. This is the conclusion. Thank you.